probably been told that if a medicine is sold over the counter, it must be safe. You take one for your knees, one for your back, and get on with your day. No big deal. But the heart of an older adult lives downstream of every pill. And there is one kind of drug that quietly raises the risk of heart attacks, strokes, heart failure flare-ups, and dangerous blood pressure spikes far more often than people realize. I'm not talking about something exotic. I'm talking about the everyday anti-inflammatories most of us keep in the kitchen drawer. The non-aspirin NSAIDs like ibuprofen, diclofenac, naproxen, and their cousins. In this conversation, I'm not here to scare you or to take away your pain management. I'm here to translate the science into choices you can live with. By the end, you'll know why these drugs stress older hearts, how fast that risk can show up, who is most vulnerable, what safer pivots look like in real life, and how to build a plan that protects both your comfort and your circulation. Think of your arteries as flexible garden hoses, and your kidney filters as delicate sieves. With age, those hoses get stiffer, and the sieves more sensitive. Non-aspirin NSAIDs do several things at once that matter in this landscape. First, they make blood vessels tighten and help the body hold on to salt and water. That drives blood pressure up, sometimes within days. Second, they shift the clotting balance toward stickier, a problem if plaque in a coronary artery is already unstable. Third, they can reduce blood flow to those kidney sieves, which pushes pressure higher still and sets up the kind of heart-kidney tug-of-war that lands people in the hospital. Put simply, they add force to the system and take away some of its safety valves. That combination is why heart risks with these drugs aren't just theoretical. Regulators strengthened their warnings when large analyses showed that heart attack and stroke risks rise even with short courses, and rise further with higher doses and longer use. The timeline is not measured in years. For some people, it's measured in weeks. It helps to be concrete. Imagine a typical week for an active 68-year-old with knee osteoarthritis. The weather turns cool, steps feel creaky, and he decides to get ahead of it with 2 or 3 tablets a day of his favorite pain reliever. He sleeps better for a few nights. By the end of the week, his home blood pressure readings are 10 points higher than usual, which he blames on stress. On Sunday, he gardened, took extra pills, didn't drink much water, and woke Monday short of breath. That's not just getting older. That's medication physiology showing up in daily life. Now imagine a 72-year-old woman who takes a daily baby aspirin because her cardiologist asked her to after a stent years ago. She has a shoulder strain and reaches for ibuprofen without thinking. No one ever told her that ibuprofen can blunt aspirin's heart protective effect if the timing is wrong. She doesn't feel that interaction. She only feels a shoulder that hurts less. But her platelets are a little freer to form a clot that week than her doctor intended. These are the small, hidden levers we can adjust once we know they exist. Not all NSAIDs behave identically. Some carry a worse cardiovascular profile than others, and dose and duration matter. Among the common options, diclofenac has consistently looked like a higher-risk choice for the heart when taken by mouth, especially at typical prescription strengths. Ibuprofen raises blood pressure, and, taken at the wrong time relative to aspirin, can reduce aspirin's benefit. Naproxen has often been considered the less bad option for the heart among traditional NSAIDs, though it is not risk-free and still raises bleeding and blood pressure concerns. Newer COX-2 selective drugs were designed to be gentler on the stomach, but the class as a whole came under scrutiny years ago for heart risks. At moderate doses, at least one of them stacks up similarly to ibuprofen or naproxen for cardiovascular outcomes, which is not the same as safe. What matters most day-to-day is not memorizing brand names. It's understanding that the heart risk is a class effect, that it rises with higher dose and longer use, and that people with existing heart disease, kidney disease, high blood pressure, or heart failure, and people on certain medication combinations are the ones who most need a different plan. Let's talk about those combinations because they explain a lot of emergency room stories. If you take a water pill, a diuretic, and an ACE inhibitor or ARB for blood pressure or heart protection, the third piece you don't want to add casually is an oral NSAID. That trio can dehydrate the kidney filter on one side and clamp its incoming blood supply on the other. Add a day of poor fluid intake or a stomach bug, and you have the triple whammy that sends kidney function tumbling and blood pressure rising. If you're on low-dose aspirin for your heart, know that ibuprofen can interfere with its antiplatelet effect unless you separate the doses appropriately. Even better, ask your clinician for a pain plan that doesn't force you to play pharmacist at the breakfast table. If you've had a heart attack and now take blood thinners, adding an NSAID layers in more bleeding risk at the same time it nudges clotting risk. None of this means you can never use an anti-inflammatory again. It means you deserve a plan designed around your actual body and your actual medicines. Pain is real, and stiffness steals independence. So what does a safer plan look like after 60 if your goal is to protect your heart without resigning yourself to misery? First, treat over-the-counter as a starting conversation, not a green light. Your pharmacist is an ally. Bring them your medication list, including supplements, and ask them to point out the red flags. Second, make topical options your first stop for joints close to the skin: knees, hands, ankles. A topical anti-inflammatory gel delivers drug to the local tissues with a fraction of the bloodstream exposure of pills, which generally means less impact on blood pressure, kidneys, and the heart. It's not zero exposure, but it's far lower. Pair that with non-drug tools that have real evidence: a simple strengthening plan for the muscles around the joint, short bouts of movement after meals to reduce stiffness and improve blood pressure, heat to start the day, ice after activity, and shoes or insoles that absorb shock. These are not glamorous, but they change pain chemistry in quiet ways the heart can live with. If you still need a pill, reach for the lowest effective dose for the shortest possible stretch, and check in with your clinician first if you live with heart disease, kidney disease, high blood pressure, or heart failure, or if you've been told to avoid NSAIDs in the past. Ask plainly which option is the least risky for you and how to time it relative to any daily aspirin. Build a boundary around use: a defined number of days, a defined dose ceiling, and a plan for what you'll do if pain isn't controlled within that window. Avoid stacking multiple NSAIDs at once. For example, ibuprofen by mouth plus another in a cold and flu combo pill. Hydrate sensibly. Respect bad weather days, hot days, and illness days as times when your circulation is already under stress. If you feel new chest discomfort, breathlessness, black stools, sudden weight gain from fluid, or a big jump in your home blood pressure readings, stop the drug and get care. Those are not wait-and-see symptoms. There's a question many people ask in a whisper: am I supposed to just live with pain? No, the goal is not stoicism. The goal is precision. A surprising number of older adults get more relief, not less, when they step away from the automatic daily anti-inflammatory and build a rhythm that respects their heart. For knee osteoarthritis, a short daily routine of sit-to-stands from a chair, heel raises at the counter, and easy mini squats holding the sink can reduce pain in weeks by adding strength and pumping better lubrication through the joint. For back stiffness, 10 minutes of morning mobility paired with a walk after breakfast loosens tissue and improves circulation. For flares, alternating heat and ice creates a drug-free anti-inflammatory signal. For sleep-disrupting pain, a wedge pillow for the legs or a different mattress zone can be more powerful than another tablet. And for many, acetaminophen in appropriate doses, especially targeted at specific times of day, can be part of a mix without the same heart and blood pressure concerns, though it has its own limits for the liver and total daily dose. The point isn't to become an expert in every tool. It's to keep your toolbox full of options that don't quietly raise the odds of the very events you're trying to avoid. Let me make this personal with a few short portraits. Picture Elena, 74, who walks every morning with a neighbor and takes a daily diuretic and an ACE inhibitor. When her hip flares, she adds ibuprofen for a week. She notices her ankles puff by evening and her blood pressure creeps from the 130s to the high 140s. She shrugs, until a dizzy spell scares her on the stairs. Her pharmacist reviews her meds and explains the kidney triple whammy. Elena and her clinician shift to topical gel on the hip, put a firm 2-week cap on any future pill use, add a simple glute strength routine, and coach her on a sick day plan to pause certain meds during dehydration. A month later, her walking route is the same, but the end of the day feels lighter, and her readings slide back where she wants them. Now meet Robert, 69, who takes low-dose aspirin after a stent. He keeps ibuprofen in the car, the kitchen, the bedside table. No one ever told him that timing ibuprofen relative to aspirin matters. When a shoulder injury nags, he doubles up for a few days and feels better, until his cardiologist asks about OTCs and winces. They switch his as-needed plan to a different approach and set a simple timing rule to keep aspirin's platelet effect intact if he ever does need an NSAID briefly. Robert doesn't feel the benefit in a single day, but he now has one less invisible risk button in his routine. Consider Alma, 77, with heart failure that's been stable for years. She hates asking for help and hates bothering the doctor even more. Her knees ache in the winter. She takes naproxen because a friend said it was easier on the heart. By February, her scale is up 4 pounds and she's waking twice a night short of breath. In clinic, they connect the dots. NSAIDs make her kidneys retain salt and water, which makes her heart work harder. They pivot to topical gel, a gentle strengthening plan with a physical therapist, and a short rescue plan that doesn't rely on oral NSAIDs. Alma feels listened to, not scolded. Spring comes and she plants tomatoes without the roller coaster. And then there's Jorge, 66, still working part-time in construction, who believes pain is a test of character. His back explodes after a long day lifting. He swallows pills, drinks little water, and lies down. The next morning, his blood pressure is through the roof, and his urine is dark. In the emergency department, he learns what acute kidney injury means. He recovers, but not all the way. Months later, he builds a different playbook with his team. Hydration he actually follows. A physical therapy plan that respects his job. Careful use of muscle relaxants when safe. And anti-inflammatories only with a clear boundary. He still works. He hurts less. He keeps more of the kidney function he has left. If you've heard that aspirin is good for the heart, it's worth a quick clarification. Low-dose aspirin prescribed by your clinician for a specific reason is different from the non-aspirin anti-inflammatories we've been discussing. Many older adults are now being told not to start daily aspirin on their own for prevention, and some are being advised to deprescribe it because bleeding risks outweigh benefits when there's no prior heart or stroke event. That's a bigger conversation with your clinician. What matters for today is that low-dose aspirin's heart protection can be undermined by ibuprofen taken at the wrong time, and that the rest of the NSAID class carries its own heart risks regardless of aspirin. Here's the most useful way to put all of this into your life. First, take stock. Open the cabinet and actually read your labels. Look for ibuprofen, naproxen, diclofenac, meloxicam, celecoxib, and any multi-symptom cold or flu product that includes an NSAID. If you're taking any of these most days, ask yourself and your clinician, what's the plan here? Second, pick a default. Topical first for joint pain close to the skin. If you need a pill, choose the lowest effective dose for the shortest defined period, and only after checking it against your conditions and medications. Third, set timing rules with your care team if you're on daily aspirin. Fourth, shore up the foundations that help your heart and your pain at the same time. Short walks after meals to nudge both blood pressure and stiffness in the right direction. Simple strength work so the joint is held by muscle, not wishful thinking. Sleep setups that reduce night pain, and a plate that calms inflammation without excess salt. Fifth, make a sick day plan in advance, so a bout of vomiting or a heat wave doesn't turn a stable kidney into a crisis when combined with an NSAID. If I had to compress all of this into one sentence you could keep in your pocket, it would be this. After 60, the everyday non-aspirin anti-inflammatories we reach for, especially by mouth, especially for days on end, quiet pain while quietly raising heart and blood pressure risks. And the safest way forward is topical first, pills only with a plan, and habits that reduce the need for either. Your next step can be small and specific. Put your anti-inflammatories in one place, so you see what you're taking. Add a topical gel to your kit if knees or hands are your issue. Ask your clinician or pharmacist, given my heart and kidneys, what's my safest pain plan? Set a reminder to walk 10 minutes after lunch and dinner this week. If someone you care about keeps an orange bottle of pills on the table like a salt shaker, share this video as an invitation, not a lecture. Hearts at our age are still responsive to better signals. A few thoughtful changes can give you the comfort you want and the future you're aiming for at the same time.